Our goal for this series is to bring relevant and timely topics to you on a quarterly basis, just to allow for engaging and thoughtful conversations. We're really excited on this webinar to be partnering with the Magic Foundation and are really grateful that so many of you have chosen to spend this time with us. I'm confident that by the end of this webinar, you'll have new insights into the topic of understanding your medications, lab results, and clinical trial opportunities. Now, I have to say the reminder, this information contained in this presentation is not intended to be a substitute for medical advice. So please take any individual questions to your personal doctor. We are recording this session. It will be available for on-demand viewing afterwards. So this is our second webinar in our continuing education series. Excuse me. And we've been getting really great feedback and questions from the community. Our first webinar was called Care Models and Advocating for Yourself. That is now also available on demand, and there's a link to that in your registration email. Today, we'll be discussing how to better understand your condition, your labs, and your medications. We'll also touch on the future in clinical research in adrenal insufficiency, as well as the idea of participating in registries. So as we look to the future of this webinar series, we're looking at topics including quality of life and psychosocial impact of living with a rare disease, and transitioning and care management going from pediatric to adult care. So stay in touch with your advocacy groups to learn about upcoming events. So we'll kick off today's program, Understanding Your Medications, Lab Results, and Clinical Trial Opportunities, in partnership with Magic Foundation. And I'm pleased to introduce Dr. Ajay Rao. He is an associate professor of medicine in endocrinology, diabetes, and metabolism at the Katz School of Medicine at Temple University. And Jenna Coura, who it sounds like many of you already know, she's the CAH Division Consultant for the Magic Foundation and author of the excellent book, Welcome to Congenital Adrenal Hyperplasia, a handbook for new CAH families. So, by the way, I told Jenna that I wish that I had that available for my patients when I was seeing families with CAH, because it's a soft landing at a difficult time for a lot of families. So let's recap what we learned in our last webinar about advocating for yourself, because a lot of these tips will apply to the conversation today. So for anybody living with adrenal conditions like CAH or primary adrenal insufficiency, learning how to advocate for yourself is important and can be profoundly empowering. Self-advocacy essentially means learning how and where to get information so you can understand your condition. As well as speaking up for yourself and being a participant in making the decisions that affect your health and your life. It also involves listening, asking questions, expressing your thoughts and feelings, connecting to a support system, and finding a doctor who can be a partner with you is a very important piece of that. There are some really excellent ways that you can become more confident and effective as your own health advocate. We'll go through a few of those. First is learning the basics of your condition. Anybody dealing with an adrenal disease should educate themselves because nobody understands your body better than you. So by understanding the way your condition works, you can sort of listen to your body better and be able to communicate what's happening with you to your healthcare team. And then, of course, not only is your doctor hopefully a great source of information, but the internet has tons of information on it. We all know that can be good and bad. So I strongly encourage you to utilize that resource, but to just be mindful and use vetted resources. I know the Magic Foundation has some really great links on their website with accurate and current information that's all been reviewed by medical professionals. One of the things that's really important about and self-empowerment for adrenal conditions is knowing how to accurately take your medications, especially stress dosing steroids in times of need. And then also having a plan in case of an adrenal crisis. So that means you have your medical bracelet, you have your emergency kit, and you have someone who can help you get through any stressful situation. That the idea behind this is that you are in control of your condition, not that you're feeling that it's controlling you. Another great way to empower yourself is by connecting with a specialist. So for adrenal disease, that specialist would be an endocrinologist. An endocrinologist can help you sort of detect any early changes in your condition so that you can tweak medications if necessary. I recommend that you keep track of your questions between visits, and so that you bring them to your next appointment and can make sure that you continue your ongoing education about your own condition. Another thing that endocrinologists can do is they're oftentimes up to date on the latest clinical trials. So if that's something that interests you, they should be able to answer those questions, or at least find out the answers for you. So of course, another thing is to feel empowered is to understand the treatment recommendations. Treatment for CAH in particular really does vary by every individual, but the overlying tenets are the same. And so for anybody who's dealing with CAH, whether it's you personally or you're a caregiver or you're a healthcare provider, we should all be familiar with the current treatment guidelines. And Magic Foundation is a great resource to find those. And then lastly, connecting with others. The sense of community that's clearly represented in the number of people on this call is huge. A lot of people living with rare disease, they feel alone. And so connecting with other individuals and families, for example, through Magic's support group network, can be really empowering. And I know people like Jenna, she went through it. She had people shepherd her through the initial process when her daughter was born. And now she's turning around and devoting her life to helping people. So that's paying it forward to me. And I think it's amazing. And so it's really rewarding for me to see the power of this community. So with that, we will go ahead and jump in, and I will hand it back over to Jenna for the meat of today's topic. Thanks, Jenna.
Great. Sure thing. So the agenda today allows for us to understand, the title is Understanding Your Medications, Lab Results, and Clinical Trial Opportunities. And so that's going to be the heart of this conversation. It's important to remind everyone that you should use the chat feature, ask your questions, but still remember we can't give medical advice. In this particular context, I can say some of us in this call, myself not one of them, are doctors, but we are not your doctors or your child's doctors. So please always go to your own doctor and medical professionals for questions specific to you or your child. But today's agenda is going to be about living with adrenal insufficiency, understanding your medications, lab results, treatment adherence, responding to an adrenal crisis effectively, and then talking about some clinical trials that are underway right now, and if any of those opportunities may be right for you or your child. We are thrilled with the participation today, and I know a lot of you asked questions during the registration, so many of those questions are going to be integrated into this presentation already, so thank you so much for contributing those. And we're going to start off with a polling question. So I want you to think about this, and we're going to ask some questions throughout. The first question is, the condition that I live with or am a caregiver for is A, primary adrenal insufficiency or Addison's disease, CAH, any form, it could be classical, non-classic, salt wasting, non, or other. So if we can have that polling question appear, or if it has already, I'm going to give you all just a moment to answer that. And when those in charge of the polling questions feel that they've got a pretty good response, we will see the answers momentarily, I believe. All right. Let's see. Are the polling answers ready? I'm not quite sure. Let's see.
They're not showing. I'm presenting.
Are they showing up for people? They don't show up for my view because I'm one of the co-hosts, so I'm not sure.
Yes, we can see them.
You can see them. Great. Yes. Okay. All right. Whomever is in charge of the polling questions will either try to get those responses in shortly.
I'll give you that answer. So
sure, great.
We have 7% or one person with primary adrenal insufficiency, 11 or 73% with some form of classics or CAH, and then 3 have identified themselves as other.
Okay, wow, wonderful. Okay, so we've got a nice variety of different responses here. And with that, I will turn it over to our doctor, to Dr. AJ here, to discuss the next portion of understanding adrenal insufficiency.
Great. Well, happy to be on with all of you, and thanks for joining. Again, my name is Ajay Rao. I'm an adult endocrinologist. And, I think with any sort of disease process or any condition, it's really nice to understand where we start out with things when it comes to the standpoint of looking at the hormone axis. So to really explain adrenal insufficiency and more specifically CAH, we really need to understand what we call the HPA axis. The HPA axis stands for H for hypothalamus, P for pituitary, and A for adrenal glands. And together these comprise the all-important negative feedback loop, which we'll go into in here in a second. Each have their own specific function, but when all three work together, their function is known as HPA axis. And you'll hear perhaps a lot of us talking about this when we are seeing patients with CAH. It's really the largest neuroendocrine system in the body, and it's really this cycle that controls body responses like inflammation, blood sugar regulation, and of course, stress. So let's pick a stressful event. So a nice way to think about the hypothalamus is sort of the headquarters of all of this. The hypothalamus responds to the stress emergency by really activating this corticotropin releasing hormones that you see in the small yellow dots there into the bloodstream. Next, this CRH entity tells the pituitary gland to release the hormone ACTH, adrenocorticotropic hormone, into the bloodstream. And this travels down in the bloodstream to the adrenal glands, these little walnut-sized glands sitting right on top of the kidneys, where it signals the adrenal glands to release the stress hormone called cortisol. Cortisol, as many have probably heard, modifies the body's response to inflammation, stimulates the liver to raise blood sugar, and helps to control the amount of water in the body. The adrenal glands actually also secrete another hormone called aldosterone, which regulates salt and water levels, which affects how much volume of blood you have in your body and also blood pressure. But here's the important part. When the levels of cortisol in the blood become high, there are sensory receptors in the brain which actually turn off the process. So this is sort of this feedback loop for producing cortisol. And as I mentioned, that is this negative feedback loop of the HPA axis. And this is how our body should function normally. Next slide. So, I think a good understanding of that basic slide can help us understand what happens in individuals with CAH. So CAH are disorders that are caused by disruptions in this HPA axis. So classic CAH or classic congenital adrenal hyperplasia is a genetic disorder whereby a missing enzyme, 21-hydroxylase, prevents cortisol production. More significantly, or most significantly, when cortisol, the stress hormone, isn't produced, there is actually a resultant increase in the production of androgens, which you can see here in the top right. So in CAH, treatment actually has two purposes. The first is to replace this cortisol that the body is unable to produce, which allows the body to adapt to stress, which is very important. But the second important feature of the treatment is to overcome the excess production of the androgens, or what we might think of as testosterone-relating hormones that result because of that negative feedback loop not functioning. Without the negative feedback, ACTH stimulates the adrenal glands to increase hormone production. And lack of that enzyme means cortisol production is blocked. So hormone production is kind of skewed or shunted to make more of these androgens, which can cause early puberty, acne, menstrual problems, etc. And increasing the glucocorticoid dose can suppress this overproduction of adrenal androgens. Now, adrenal insufficiency occurs when the body produces antibodies that destroy the part of the adrenal gland that produces cortisol and aldosterone. Next slide, please. So understanding your lab results. So hopefully, you've been able to see those earlier schematics and now have a better understanding of what your doctors are potentially testing. And so when your doctor requests labs to test for hormones, he or she is looking to see if your medications are properly dosed. And in CAH, the lack of cortisol leads to excess ACTH and reduced aldosterone. In CAH, androgens can be elevated, which may cause bothersome side effects like early puberty and infertility. How much medication is required to replace cortisol is usually determined by potentially your body size, also your symptoms. However, your doctor will also measure your androgen levels to determine if you're on the correct dose of glucocorticoids to control the overproduction of adrenal hormones.
All right, so we also got a lot of questions during the registration period, and we've integrated those into this presentation. So the first question that was brought up that is a good one for this topic is something that Chris asked. He said, what if you have symptoms of CAH, but some of your lab markers are normal? And in the chat, he added also, for example, low aldosterone, low or normal renin, but normal 17-OHP. What do you think about that, Doctor?
Yeah, so I think obviously any of these tests, if you're still having symptoms of CAH, any of these tests, it warrants retesting, making sure we didn't potentially miss something. Obviously, symptoms of CAH might also be connected with other problems that need to be sort of tested for by your physicians or other providers. So I think that's important to keep in mind. Obviously, the 17-hydroxyprogesterone levels being normal with some other abnormalities in aldosterone and renin, perhaps suggest different types of workup that might need to be done to investigate specifically the low aldosterone and low renin levels. But, the 17-hydroxyprogesterone is very helpful in the diagnosis of CAH and also the monitoring.
And then Subra asked, why does the 17-OHP level fluctuate so drastically, even without a change in dose?
Yeah, and this is always the struggle in clinical practice. Obviously, tests can vary. There might be a natural variation or difference in a test from day to day. However, also what might be a variable is sort of when the test was measured in relation to your last dose of glucocorticoids, perhaps the time of the day. So these things have to be sort of kept in mind when you're looking at those levels and the fluctuations. And obviously, the provider can help interpret those tests for you.
Dr. Rao, I'm going to ask a question here that just came in that I think is really important right at this point. So do you always test fasting, or can these levels be assessed later in the day?
So, a lot of I think that's a great question. And, obviously it's always, potentially tedious to always have to go in at a certain time of day for blood work. But I think a lot of our tests that are used in this setting and pretty much a lot of hormone testing have a lot to do, could see some variation with fasting or lack of fasting, and also sort of the time of day. There's sort of a rhythm in a lot of our hormone measurements. So I think it is important to test in the way as suggested by the provider who's ordering the test. Typically, again, should be fasting and in the morning.
Thanks.
So we're going to go on to next sort of look into the role of steroid treatment and the importance of this. So it's really important to understand what medications you're being prescribed by your doctor and why. And it's rare, but in the event you must seek medical attention in the emergency room or emergency department for an adrenal crisis, you might have to help the doctors understand the stress dose needed with a sort of high dose corticosteroid. So glucocorticoids are steroid replacement therapy as they replace the missing cortisol that we talked about earlier needed by your body. Supraphysiologic, so physiologic being sort of what you typically need, and supra meaning higher than those doses, are sometimes required to restore that balance, suppress those androgen production, and prevent an adrenal crisis. Now, mineralocorticoids, such as fludrocortisone, are prescribed for salt wasting forms of CAH and Addison's disease to maintain body fluid and sodium balance. So it's a slightly different role for the mineralocorticoids.
So we have another question that came in from the registration process, and Jamie asked, what are the most important factors to consider when dealing with a salt wasting CAH patient as they process into their latter years, if they're 60 or more years old, for example?
Yeah, that's another great question, and something that for example, somebody like me who's an adult endocrinologist is always trying to figure out the best course. And this is a very interesting question. And things change as we get older, and perhaps what are the benefits and what are the risks might change over time. And we'll talk a little bit about this in the next couple of slides. So can I have the next slide, please? So, treating CAH, and this goes to that question, as folks get older, we really need to sort of choose and really get into this sort of balance. And I think it's a delicate balance that's needed. So patients and physicians may have to choose between sort of the detrimental effects of high androgen levels. So you can see here, excess androgens could cause problems with hair growth, acne, psychological effects, weight gain in places that may not want it to happen, short stature, infertility, and then this has to be balanced with the consequences of high dose of glucocorticoid use, such as heart disease, short stature, high blood sugars, osteoporosis, and also obesity. So, I think as people get older, these factors really have to be reconciled, and this balance really needs to be achieved in a delicate manner.
We are on to our next polling question. So all of you get your computer mouse or a phone finger ready to go. Our next question is, what medications do you currently take for adrenal insufficiency? Or if you're a caretaker, what medications are you giving to your person you are caring for? Hydrocortisone, prednisone, prednisolone, methylprednisolone, or however variation of that you pronounce it differently, dexamethasone, fludrocortisone, solocortef, other, I don't know, or any combination. You can select more than one answer here. So I'll give everyone a few moments. It's letting me answer as well. I'm going to answer right along with you. Got 3 answers for my CAH kiddo. And we'll see if we can get some responses in a moment. All right, it looks like the majority take hydrocortisone and a bit of fludrocortisone, a smattering of prednisone and its similar medications, and dexamethasone, and a whole lot of solocortef there. All right.
So it's really nice to see the variety of steroids that folks are on, so we can kind of go into some of the common corticosteroid agents that are available. So this slide shows a comparison of glucocorticoid preparations with the shortest acting hydrocortisone shown compared to these other glucocorticoids, as well as the mineralocorticoid fludrocortisone. And so you can hopefully see here that these are potentially the glucocorticoid strength of the hydrocortisone and how this compares to prednisone or prednisolone or methylprednisolone, and then also how this compares to dexamethasone. Fludrocortisone has a prominent mineralocorticoid effect, but really doesn't have any glucocorticoid effect. And so you probably see a lot of patients taking that in tandem. So here is a nice quick reference for the most common symptoms of adrenal hormone replacement, excess and deficiency. And I think this is important for us to know as providers, but also is really crucial for patients to have a good understanding so they're able to report these back to their providers if they're experiencing them. So taking too much of the glucocorticoid can result in common symptoms such as weight gain, fatigue. You might notice yourself bruising more easily and wondering where that's coming from, muscle weakness, redness in the face, mood swings, and inappropriate hunger. On the counter, if you are having symptoms of too little, sort of might see the opposite: weight loss, weakness, severe fatigue, nausea, and loss of appetite, and potentially changes in your skin pigmentation. Now, if you take too much of the mineralocorticoid, fludrocortisone, you might notice sort of a problem with managing high blood pressure or having high blood pressure. Could notice ankle swelling, and exertional headaches, so headaches when you're moving around. And if you have too little of this, you're going to have problems with reductions in blood pressure, nausea to the point that you're vomiting, and that might make it even more difficult to take the medications, dizziness, sometimes to the point of passing out, salt craving, and then potentially muscle cramps.
Dr. Rao, if we can go back to that slide, a question came in earlier. So based on those symptoms of excess or deficiency, would you expect your lab results to be out of range, too high or too low based on some of these symptoms? Would your labs be able to tell you that?
Yeah, so, I think that's the one thing that's always, why it's not just doing one thing or the other. It's usually involving both it usually involves both the lab tests and the symptoms. And a lot of the providers will be interpreting the lab work in the context of what symptoms the patients are potentially having. So I think the answer to that is it's always important to report these symptoms irrespective of the lab tests. And the lab tests alone are not what we completely rest our hat on. We rest our hat on not only the lab tests, but also how the patient is potentially feeling and what sort of symptoms they're experiencing.
And one last question that just came in, if you can work this into this slide. So testicular adrenal rest tumors that we see in men, TARTs, is it a facet of too much or too little of glucocorticoid or mineralocorticoid?
Yeah, so I think this is it is a long-term sort of effect that we do see in patients, and it could be related to achieving sort of that perfect balance. And these things need to be monitored closely with imaging, and we're hoping, whether it be with current treatments or future treatments, that we'll have a better way to assess these problems and hopefully not have issues pop up with those TARTs. And so it can be somewhat managed with changing some of the treatments, but in the end, it ends up becoming, it's difficult to find that perfect balance for a lot of patients. And hence, I think there is definitely a big push for discovering therapies that might help that from not happening or developing.
Thank you.
Great questions. So we'll next go into treatment adherence, and really this can apply to any sort of disease entity. and is not necessarily specific to CAH, but obviously has a definite importance in this space. So sometimes we will talk about this as treatment adherence. Sometimes you'll see it called compliance potentially, if you have ability to look at your charts with your healthcare providers. So, I think the most important thing with any sort of condition is medications can really only help you manage your health, but only if you take them. And typically adherence rates of 80% or more, so taking it sort of 8 out of 10 times or more, are needed for optimal therapeutic sort of efficacy, meaning that you're actually getting what we think you're getting. But it's estimated that adherence to chronic medications like those that we use to treat CAH is actually more around 50%, so quite low. And adherence rates can go down as time passes after the initial prescription is written, or as barriers emerge or potentially multiply. And so, it's really important to take your medicines, know what to do in the event you miss or skip or forget to take your medication, because this is going to happen. I think the most important thing is talk openly and honestly with your pharmacist, your provider. If you're having difficulty affording the medications, let them know so they don't think you're taking the medication and then get confused when they see certain results. A lot of mobile health apps are around to help remind you how to take your medications if needed, with different types of alarms, and that can be very helpful to make sure you're not missing your medications.
We've got another polling question for you all. An increase in glucocorticoids is needed in which of these situations? So an illness with fever, illness or increased physical activity, increased emotional stress, unusual work-related stress, dental work, surgery, or all of the above. All right, I'm going to play along with everyone here and see what sort of results we get. All right, do we have the results ready? All right, it looks like a lot of people said illnesses with fever, less responses for most of the next one, dental work, surgery. A whole lot of people, 62% said all of the above. So Dr. Rao, what do you have to say about that?
Yeah, so, I think adrenal crisis is really something we want folks to be prepared about, and sort of the point of that question. So, being prepared in the event of an adrenal crisis is really, really important. An adrenal crisis is considered a medical emergency and should really be taken quite seriously, and could potentially be life-threatening. And understand what can cause an adrenal crisis and what you need to do is really crucial. And you should ensure you have information to share about your treatment of one's treatment of adrenal crisis. Tell your close friends, tell your roommates, tell your workmates, so they know. There are some adrenal crisis care letters for emergency room staff that can be found at the websites noted below, the Magic Foundation, CARES Foundation, and NADF. And this can be really helpful for folks when they go into the emergency. The emergency doctors may not be aware of what to do. They might be going down a whole different line of treatment for you when it might be something so crucial and related to an adrenal crisis. So that's really important to carry around and have available with you.
Another polling question for you, just making sure everyone's awake. I know it's been a long Monday and Tuesday already, but let's move on. The next one, empowerment through preparation. Do you have a Solocortef injection kit? And do you know how to use it? So yes and yes, yes and no, no and yes, no and no. Do you have that kit? And if so, or if not, do you know how to use it? Let's see. We'll wait just a few moments while everyone thinks about if they forgot where their kit is and when they last saw their injection training videos or injected into an orange Yes and yes is the majority with 64%. Yes, they've got the kit, but no, they don't know how to use it, 18%, and nope to both at 18%. So a bit of everything happening here. All right.
So, I wanted to just comment on some nice points here in the chat. First of all, I think, with the adrenal crisis, I think a lot of times the double dose is something that might be said a lot by providers when there's some changes or some stress that you're experiencing. I think emotional stress, I typically is not something that I tell my patients to double up, but we do know that, and we need to recognize that emotional stress can connect to other stressors. And so that's really important to keep in mind, and it could lead to triggering for other stressors that do warrant changes in treatment or seeking attention from sort of an emergency health provider. We were talking a little bit about the Sol-U-Cortef and sort of what is sort of the next step here, and it looks like a lot of you mentioned that you either have know of it or you do know how to use it, or you don't know how to use it. So it's really important, I think, to make sure you have an ability to have that prescribed for you, and that you have a way to understand how to use that, because that might be very important in settings where you're unable to take anything by mouth. And that's really important to keep in mind, because that can happen. So I think with any type of condition, we're looking not only to the past to learn from what we've done and what's worked, but also what's currently working and where we're going in the future. So really, for the past 70 years, the only therapy for CAH has really been using sort of this delicate balance of glucocorticoids, or GCs, and there's really not been new treatments in over 70 years. So, I think GC is great because it suppresses the HPA axis, but we do know that there is long-term side effects of high-dose GC therapy, and so this treatment landscape is rapidly changing, and we're hoping the future is going to hold more options. So there are some cortisol pump studies available, so using devices to deliver the glucocorticoid in a sort of stable and continuous fashion, kind of like what your body might naturally do. Modified release hydrocortisone, auto injection for adrenal crisis. And then, going back to that initial schematic we showed, antagonists or blockers of that corticotropin releasing factor are actually undergoing clinical trials. And to a point, a question that was brought up earlier is gene therapy and clinical trials there. And I think these things, the timeline for gene therapy is, these things take time. One's is to develop them and then to test them in the appropriate population. And the most important thing is to make sure they're safe. So I think it's hard to comment on that right now, but I think they are up and running. And coming hopefully in the nearer future. It is frustrating to not see treatments in the last 70 years, but I think at the same time, these treatments take time because we're just maybe further understanding how the CAH problem, kind of expresses itself in patients who are now living full lives. So hopefully we have a better understanding as time goes along, and hopefully that we won't be saying this, we won't having the same slide again 10 years from now or 20 years from now, that we were seeing a lot of treatments. So is a clinical trial opportunity available and right for you? And I think this is always a struggle for many patients who are curious, when is it right to do this, and what could be the benefit for one's own health or others. So, as I previously mentioned, there's been tremendous frustration, no new drugs in this space for nearly 70 years. But now is really a very exciting time for those living with CAH, as there are many active clinical trials for adrenal disorders. We would particularly note that for classic CAH, recent research has added new opportunities and complementary treatment that may allow for reduction in glucocorticoids. And many individuals and caregivers ask why should we be involved in clinical trials or clinical research or any sort of patient or human-oriented research? And I think there's three important reasons to consider a clinical trial. So the first thing is the potential for more effective drug delivery, the potential to reduce the glucocorticoid use in individuals with CAH, and really an important part of this, which is the potential to improve treatments for not only oneself, but potential the future generations who have this problem. But we understand that in the end, it's a personal decision and a one that should be discussed openly and candidly with your physician. And you can see here there are a variety of trials that are available and for classical CAH. So it's something to keep in mind. But again, in the end, it's a personal decision.
We're going to do a little summary of what we've talked about today. And so to start, just the biggest thing is to learn the basics of your condition, to have the basic understanding of what is happening in your body or in your child's body, if that may be the case, what these medications are intended to do, what these labs are checking, and what a high result, a low result means, what sort of adjustments might be expected. Also, something that's incredibly important is making sure you feel like you can advocate for yourself or advocate for your child. And that may look like a lot of things, at least for my family. It means feeling confident in the medical team overseeing your own care or your child's care, feeling like there's a team dynamic going on when discussing medical things with the doctors, and feeling like the team you have in place is your support system, that you can ask stupid questions, you can ask smart questions, whatever questions, and you can bounce ideas off of these doctors that you work with and make sure that they'll take you seriously and really listen when things aren't going well, and when things are going well, of course. So if you have certain triggers that seem to be causing a need for extra a cortisol boost, and it doesn't quite fit that box, that your doctor would listen to you and work with you and find out and maybe create some troubleshooting things that you could try, so that you can feel well, because that should be the goal, that you're not just living with this condition and plodding along, but feeling well and hopefully thriving. So really get to know your condition, all the different angles of it, and CAH especially just has so many layers to the way it impacts an individual. Another thing is to just know what to do in case of an emergency, in case of a crisis. Have that kit with you, have that medic alert bracelet, have people around you who know what to do and can advocate for you if you are not able to advocate for yourself. I'm going to throw in a little tip here that I learned in a recent webinar from some adult CAH patients, that when a patient turns 18, their parents can no longer make medical choices for them legally without a letter. So if you're the parent of an 18-plus-year-old and they still rely on you to help them with medical emergencies, get a notarized letter giving you authorization to speak with doctors about their care. If you're an adult with CAH or with Addison's disease, have another adult, either a spouse, an adult child, a sibling, someone you trust who knows your condition, who can be that advocate for you in an emergency setting. Have that support system in place. My personal rah moment here is to connect with other individuals. That can be online through Facebook groups. The Magic Foundation has excellent adult patient and parent groups. The parent group is a very large group, and I always joke that they're the nicest internet strangers you will ever meet. And I really mean that. I know most of you are in that group who are on this call now. And if you're able to meet in person with other families, if you meet people from the internet, just make sure that's ideally in a safe public environment, because the internet. But if you have the opportunity to meet other individuals with your condition, it can be very empowering just to talk about it with someone who gets it. And if you're a parent, it's really amazing to see your children grow up playing with other kids who also have their little medical alert bracelets. It's just beautiful for them to grow up knowing other people like them. So also consider if a clinical trial might be something worth pursuing. It might be something that you want to look into. There are many trials underway right now. They may not be right for everybody. They may be something that you are excited about. You're something you just want to learn about. There's something you're feeling a little cautious about, but you want to educate yourself about yourself anyway. I tell people that this is, getting a CAH diagnosis is not something anybody wants, but this is the best time in history to get slammed with this particular diagnosis, because there's a lot of hope. The trials don't come with guarantees or promises necessarily, but they certainly provide a lot of hope that the future for CAH is going to look a lot differently than the past. So if that's something that interests you or that you just want to learn about, there's a lot of trial opportunities underway. So with that, we're going to get into some question and answer time. Many of the questions that were asked in the chat have been addressed. I've been noting them all along as well, though. So I'm going to jump into one of them that came in as a last minute registration question that said, do people with CAH always have to take medication?
Yeah, that's a very nice question, to bring up. And I think, the short answer is you do need to be taking something definitely on a daily basis, right? As we talked about sort of where things are moving with one's hormones. And I think, I know sometimes when we think of medication, we're thinking maybe something foreign or something created to block something. In this space, a lot of times we're giving exactly what your body needs in the form of a tablet. And so I think the answer to your question is yes, but it's sort of giving back to your body what it actually needs, is kind of how I would term it.
And then another question, is the hydrocortisone treatment damaging to the kidneys? Does the cortisol create any severe side effects in the long run?
Yeah, so we touched on a little bit of those, the glucocorticoid excess problems, whether it be problems with your bones, concerns for osteoporosis, but potentially if you're getting way too much and it's not balanced properly, the chance for weight gain or issues with your blood sugars, problems with, potential development of diabetes. Obviously, the lucky thing when it comes to the so one may think that is the kidney have a chance of getting damaged because it's so close to the adrenal gland, and I think that's a great question. Typically we are monitoring that with most of our routine blood tests, and so that would be caught very, very easily. Sometimes you can have brief changes in your kidney function, maybe in a setting where you get very dehydrated or well behind with your steroid use for a crisis, but all of that is reversible. I think in the long run, the kidneys should do fine as long as there's no other reason for you to develop a kidney condition separately.
Thank you. And then this one may be a pretty broad question, but perhaps you can give a quick version of the answer. What is the ideal lab result ranges for each test? And this question is specific to pediatric, but perhaps it would pertain equally to adult patients.
Yeah, so all of these tests will, you can find what we call the reference range typically on any sort of commercial website and asking for the particular lab you're interested in. And there will be potentially pediatric ranges for a lot of these hormone measurements. However, I would say that those reference ranges and those levels will be interpreted in the context of what the patient has and how the patient is feeling. So it's hard for me to just list out the reference ranges off the top of my head, but I think those are things that should be available to you, and you can definitely ask your provider for what you think the target and ideal lab result should be.
Excellent. Yeah, it's a tough one. It's got a lot of, well, it depends, right? That's a lot of a lot of these. Well, let's see. Another one that was asked is, can too much glucocorticoids cause migraines?
Yeah. So, I think, obviously it's good to make sure there's no other reasons for having migraines, that you don't have a separate migraine condition. I think too much steroids can always be, could cause a variety of issues. And I'm sure I've had a couple of people who've experienced that. But again, it's really important to make sure it's sort of evaluated in the context of actually making sure that the person is getting too much steroids from the lab tests or from what we think they need to be getting from the standpoint of their total steroid dose, and also making sure that they don't have a separate chance of having migraines.
All right, this is a question from a parent who has a son with the 3-beta form of CAH. They ask, can you comment on the DHEA levels, or is it better to obtain DHEA sulfate?
So maybe, so I'm an adult endocrinologist. So Dr. Charlton, I was wondering if maybe you could take that question, if you don't mind.
Sure. So the difference between DHEA and DHEA sulfate is that the DHEAS is specific to the adrenal glands because it's the same hormone, but it can be produced other places, but only the adrenal glands sulfates it. So generally speaking, people will pay close attention to the DHEAS. That said, I can tell you the way I was trained is that I would always order both. And in peds, what we generally do is we take a broad swath because, as I know somebody mentioned earlier, the 17-OHP fluctuates a lot, different times of day, different stress levels, things like that. So there are so many moving parts to this. So each individual child, we want a broad palette to give us an overall context. So my guess is your doctor probably orders both, but that's sort of the difference. I think probably of the two, DHEAS may be more informative. But I would get both.
Excellent. All right, here we have another question. What's the best way to find an endocrinologist who is proficient in adrenal issues? Most seem to specialize in thyroid, diabetes, and androgens.
Yeah, in the United States, and actually even I think internationally, the Endocrine Society website is a nice go-to area. There's sort of a hormone health section there. There's a section there where you can look up physicians who have specific interests, and hopefully they have the provider has denoted their interest in those items. Obviously. It's also helpful to look at profiles of physicians on the health system or practice website, and hopefully they might mention their interest. And also we talked about centers of excellence that are around and available in the country, and that obviously makes it easier to find those folks. And a lot of times just reaching out, your primary care provider may know of folks in the general area or near to you, or who to at least start with to find out. I would shy away from just the sort of the random Google, because that can, sometimes get you results that might be a little bit confusing. So I think I personally would use the Endocrine Society website, and I think it's very patient facing and friendly.
Excellent. There's another question here about the difference in terms of effectiveness of hydrocortisone tablets versus solubles or compound forms and the new Alkindi sprinkles. Do you have any thoughts on those differences?
Yeah, I mean, I think it's great to have those options. The soluble tablets have to be dissolved and mixed in the water. I think these things, it's obviously they wouldn't be available if their effectiveness wasn't tested to be equivalent. But I think, again, to sometimes testing it in general versus testing it within the CAH space is always something that's always challenging. So always make sure if these changes are being made that you're having a nice discussion with your provider about some of those symptoms and also the blood tests to make sure that those are indeed being as effective if you do have a change.
Excellent. I think we've gotten to almost all the questions at this point, except I see that there's a question about, is there any optimism in the idea of doing a kidney or adrenal gland transplant to help with CAH treatment?
Yeah, I have not seen literature on that. Obviously, if we those sometimes it's easy to think of transplantation as solving the problems, but that might introduce a new issue of being on a bulk of medications to suppress your own body's immune system against these new organs that you have received. Same problems may happen again in the organs that you've received. It's hard to tell. So I think we're hoping more that maybe the ongoing clinical trials give us better options than coming to that point, which necessitates transplantation.
Thank you so much, Dr. Rao. And I see, thank you so much, Chrissy. It seems I saw your comment about, Krista, about you read my book. Thank you. I'm glad it was helpful to you. And I have plans for a second edition that will have a little or a little sentence added to discuss the different ways that gene mutation can come about. But wow, your case is certainly an exception to the rule, and I'm glad you got some information, but I'm sorry that happened. And I'm going to turn it over now to Dr. Will. Thank you so much.
All right. Well, thank you so much for joining, everybody. Great questions. I hope that you had a lot of food for thought, and we'll think about, how this discussion might change the way you approach living with CAH or other adrenal disorders. So on behalf of Spruce, I want to thank Magic for partnering with us and for all the work you do in the communities. And particularly special thanks to Jenna for hosting, to Carol Ogg for putting the program together, and for Dr. Rao for providing his expert insight. So we will wrap up for the evening. As you know, we recorded this session and we will send a link out to you via email once it's posted for on-demand viewing.